8, Professor Salim Abdool Karim is our special Wednesday guest, where we get to spend most of the hour with someone very high profile, and all of our viewers wanting to see you, Prof. So we really appreciate you staying with us as well for the next couple of minutes as well. Someone wants to, and you heard me talk about the tweet coming through, I'm a pata pata on Twitter, asking if you're going to be the health minister. You can answer that in a minute. Before we get there, there's more to you than just COVID-19. It's your HIV/AIDS work that I think people know you hold so close to your heart. Is that why you stepped away from the COVID side of things? Why did you do that?
Well, when I took on the responsibilities in COVID-19 in working with the Department of Health and the government, I couldn't really manage both my HIV work and my COVID work. And what was happening was that increasingly I was being called upon to give advice in many different settings and several governments. And so to manage all of those responsibilities, I decided that I needed to step down from an official role in the Ministerial Advisory Committee and focus on my much broader role. And I've now split my time. So I spend just about half my time on HIV and about half my time on COVID-19.
Yeah, and in terms of HIV and AIDS, Prof, how far is that work? Are we any closer to a cure?
So I'm actually very excited. I've been working on HIV vaccines for quite a while, almost 35 years. And I have never felt that we are as close to a vaccine as I feel we are now. And the reason for that is because we have been able to discover, when I say we, I mean the scientific community, that there is a way in which to prevent HIV from occurring using antibodies. And they are very specific antibodies. They're called broadly neutralizing antibodies. And we've discovered them even here in our patients in South Africa. And we've been developing these broadly neutralizing antibodies as part of a strategy to guide us as to what in the immune system will enable us to develop a vaccine. So a vaccine, in my view, it's not going to be available in the next few years, but I can see that it is possible now. We've just got some technological hurdles to overcome. But say within the next 5 to 10 years, we are probably looking at candidate vaccines that would at least provide some level of protection.
And Prof, I just got another tweet here. I'm trying to see them as I'm going through my Twitter account at Gareth Edwards SA. Guys, I can't see all of them, so I'm trying to just grab one or two. There's so many coming through, Prof. Because I want to ask about monkeypox in a moment, just before we have to start saying goodbye to you. But this is from @John Wilson. There's a lot of numbers. I'm not going to read them all. @John Will. Another question for the Prof, please. Are masks still really necessary? People only wear them when going into malls and shops, but no one bothers with them anywhere else, like wearing them out in public, for example. Where do you stand on the masks debate at the moment, Prof?
So there's no question that masks work. In laboratory studies, they've been shown to work. In large clinical trials, for example, done in Bangladesh, they've been shown to work. They work less effectively when you're dealing with more infectious variants. So, for example, with Omicron, it's such a highly infectious virus that the masks become less effective. Now, when we are dealing with an outdoor environment, the masks really become superfluous, and that's part of the reason why I was among those that strongly supported the dropping of masks in the outdoor environment. But in an indoor setting, particularly in public transport, there's a very strong case to be made for ensuring that you are still using masks, especially in a situation where ventilation is a problem. And we know that that's a problem in buses and trains and taxis where people are squashed up all together and it's cold and they don't open the windows or you can't open the windows. So we need to have masks because it's really the only form of protection, as partial as it is. So there is a case to be made for the use of masks in certain settings. But for me, the bigger incentive or the more powerful way in which we can protect ourselves is through vaccination. By ensuring that in indoor settings we are restricting it to people who are vaccinated, that is our better protection. And you can look at having both together would be even better, that we insist on vaccination and mask wearing, so that, because there's really superb evidence right now that shows that individuals who are vaccinated, even if they get breakthrough infection, which is occurring, we're seeing that, even when they get breakthrough infection, they have a much lower chance of spreading the virus to others. In one study published in the New England Journal of Medicine, it was a 68% lower risk of spreading it to your household contacts, to your people you work with, and that's what we need. We need to try and slow down and prevent the spread of the virus.
So, Prof, with that being said, what are we likely to see next with COVID-19? Is it becoming more like a regular flu, a common flu, or are we still going to be in this almost endemic, pandemic kind of phase with COVID-19? What do you foresee with this virus?
I think when you look at the first 4 variants, alpha, beta, gamma, delta, each of those variants was worse than the one before. So in other words, progressively, the virus and its mutations were leading to more cases, more hospitalizations, and more deaths. So the overall trend up to the Delta variant was one of a virus that was getting progressively worse. Omicron has changed that. Omicron, because of its multiple mutations, when you compare the other 4 variants, they had, up to around 8, 9, 10 mutations. Omicron has over 50 mutations. So Omicron now is more infectious but milder because it's less able to infect the cells of the lungs, but it's about 70 times more efficient in infecting the cells of the nose. And so it's able to spread much more rapidly. But even Omicron, with its being a milder virus, among the elderly, it is quite a severe infection. So we can't just disregard it in that sense. Also, we have much more people now with vaccination, more with natural immunity. So we have all of these mixtures of factors that have led to a situation now where with the Omicron and its subvariants, we don't see as much hospitalizations and deaths. But that doesn't mean that the next variant is going to be like Omicron. The next variant could just as easily be more like Delta. So we have to be careful that we don't get complacent. We all live in hope that the next variant is going to be milder, easier to deal with, and that progressively over time, it'll just become a minor cold. But that's the part we wish for. Yeah. It doesn't mean that that's the part that's going to happen, and that's what we need to be ready for.
And that's what we need to hope and wish for. Prof, we could spend all day talking to you. We really could, but I'm going to leave this as a last question to you. I was going to ask about monkeypox, but perhaps we'll keep that for another day as well. But what I want to ask before I ask about monkeypox, Prof, is that tweet from Amapata Pata on Twitter. Would you take up the position of Health Minister if you were asked?
I mean, the answer is simple, no. I'm not good at playing the politics. I believe in following what the evidence shows. I have little tolerance, for dealing with all these sideshows and people with their own vested interests. I can't deal with that.
Okay, then my producer telling me
Minister,
Go ahead.
No, I wouldn't survive a week in the job. You know, it's not something I would do.
Prof, my producer saying we can sneak this in very quickly. We do want to talk about, I'm sorry to end it on something that's viral again. I was hoping to end it on the ministry question. Monkeypox, just very briefly, Prof, how worried should we be about something like monkeypox, just before we say goodbye?
Sure. So monkeypox is very different from SARS-CoV-2, very different from COVID. Monkeypox is a double-stranded DNA virus. COVID-19 is from an RNA virus. Also, monkeypox, you know, it really is a virus of rodents. You know, it's not even in monkeys naturally. I mean, monkeys do get it, but it's not normally in monkeys as the prime host. But when it infects humans, it is not easily spread. And that's why we've seen sporadic cases of monkeypox, and we don't really worry too much about it because we can control it. Fortunately, we have a vaccine against monkeypox. Well, the original smallpox vaccines work against monkeypox, so those of us who've been vaccinated against smallpox, which was those born before 1970, we still have some residual protection against monkeypox. But there's a new vaccine that's been licensed for monkeypox, so we have a vaccine. What we need to understand is that monkeypox is not like COVID, and it's unlikely to become the next pandemic. What it's going to be, it seems that this virus, the current version of it that's spreading, might be a little different. And so we'll need to, the early evidence suggests that it's not in its genetic code, but we're waiting for more data. But as it stands, we should be able to control monkeypox. We've been able to do it repeatedly in the past. So I'm not anticipating it'll be a runaway pandemic like we've seen with COVID-19.
Well, we can't thank you enough, Prof, for making time to speak to us this morning. Thank you so much for joining us. Thank you so much for the work you've done over the years, not only in COVID-19 the past 2 years, but also with the HIV and AIDS research alongside your wife. I understand you've been dedicating over 35 years to research, and quite optimistic, you say, Prof, about where we are and where we are still to go with that vaccine for HIV. Professor Salim Abdool Karim, thank you so much for joining us right here on the South African Morning.
Still